Prego, prima i più anziani.
Ask if there are any questions among the audience, and if you have a question, please raise your hand, and they will bring over the microphone to you.
Okay, actually it's not a question, it's a comment. As I mentioned, we are measuring polar bodies for aneuploidy. And according to our experience, the percentage of aneuploid metaphase 2 oocyte will be higher in the advanced maternal age than the aneuploid blastocysts, because some of these aneuploid oocytes which are fertilized will not reach the blastocyst. So you have a first selection in going to blastulation. So when we look at age group of 41 to 43, the euploidity rate is even less than 10% when you look at the oocytes. And I think this is important to know because some years ago, I think 15 years ago, the University of Brussels published a paper on about 25,000 cycles, and they looked what was the number of oocyte needed according to the given age to reach one live birth rate. And at the age of 43, I remember that for particularly, it was 123 oocytes needed. Yeah. And during the same time, we looked at about 20,000 cycles that we have done, and look what was the number of oocytes that we needed in each subgroups to find one live birth rate. And the age of 43, it was 123 oocytes. So exactly the same like the Brussels group. We also looked at 45 years old. That was 250 oocytes needed to reach one live birth rate. So I think that gives us some image also about counseling patients at that age group. What are the odds to reach a live birth rate?
Yeah. So there's room for the 10 stimulation.
I am going to announce we were using a tablet to follow the questions online, and I think the tablet ran out of power. So I'm not sure if we're not addressing your question because you're sending us an online question. I apologize. Are there other questions in the hall?
Yes, I have a question to Dr. Ubaldi. Here?
Yeah.
Hello, Filippo. I'm Andreas Tandler from Berlin, Germany. And I would like to ask you, we do have quite a few cycles done with your double stimulation or dual stimulation. And the experiences are good as well with those patients who have eggs and blastocysts in the second phase of the cycle, in the luteal phase. But on the other hand, there's quite a high amount of people who do not reach a follicle puncture in the second phase of the cycle. So can you please comment on what is your personal experience and the data concerning those patients who do not reach a follicle puncture in the luteal phase?
So we have 7% of cycles in those huge amount of number of cycles that did not reach the oocyte aspiration on the second stimulation. And the reason why it's like this could be two times. One, if you give ACG as a trigger in the first stimulation. And second, if you do ultrasound on day 4, day 5. You should forget to do an ultrasound until day 6, day 7. And you should give the agonist trigger. If you give the ACG, then you will have the corporal lutea that will last for 7, 8 days and will not allow the new cortical follicle to start growing. If you give agonist trigger, the corporal lutea will be until day 10 from the oocyte retrieval, so until day 5 of the second stimulation. And if you look at that, then you think that it will nothing happens. And then you are prone to stop the stimulation because you don't see any follicles, you see only corporal lutea. So first, not to do an ultrasound before day 7, day 8. And if it does not menstruate, you have not be afraid that the LHP could be start. Or if you want to be secure that you will not have the risk of premature LH surge, you start giving a progesterone at the beginning of the second stimulation. And you do an ultrasound on day 8, day 9. And then there you see what's happened. When you do the second oocyte retrieval, you cannot recognize that the same ovary has been stimulated 20 days before and went to the oocyte retrieval. You cannot see any sign of a previous stimulation. So the two reasons are this. Either you give ICG and then, of course, it will be too long and then you are obliged to stop because you will keep on having corporal lutea, or you do ultrasound too early, then you're scared and then you stop the stimulation.
Good morning. Here, Filipa from Portugal. I have a question for Professor Lamarca. Could you comment on those patients that have normal AMH and low follicular count, or vice versa?
Sure. Okay, yeah, thank you. First of all, none of the two markers are perfect. This means that, well, sometimes you may have a good value for AMH or antifollicle count, but the patient will has been categorized wrongly. So you expect a poor response, she will respond perfectly. But coming to your question, AMH is a hormone which is produced by the ovary, by the granulocyte cells, then secreted into circulation, then it goes into the blood, and probably it is bound by some proteins into the serum. All these steps may be affected by some biological variability. So this means that what you are measuring into the blood does not necessarily mean that you are measuring exactly what produced by all antral follicles. The same is also true for the antral follicle count. With ultrasound, you cannot really identify all antral follicles which are within the ovaries, because there are follicles as smaller as 0.3, 0.2 millimeters, which can be recruited by the ovarian stimulation, but you cannot identify these follicles. And secondly, and most importantly, when you identify antral follicles within the ovary, please keep in mind that not all antral follicles are healthy. A certain percentage of those follicles is growing up, but another percentage of follicles is going down, is going through atresia. And this rate, the rate of atretic follicles, is an individual characteristic. That's why you may find sometimes a discordance between the two markers. Then what to do? I mean, as I always say, I think you may and you should rely on what you think is the marker measured in the better way in your own setting.
Thank you. My question is for Professor Ubaldi. Since you recommend the agonist trigger for the second cycle, and referring to the study of Fatemi, who showed that the lipolysis is different from women to another. Do you think, and you mentioned that with HCG we can maintain the corpus luteum 10
Longer.
days or more, do you think, or do we have to measure progesterone and start the follicle stimulation? Yes, I didn't do that, but
No, you don't have to do anything. On day 5 or day 6, so what we do now, we see whether it's worth it to start the second stimulation according to the number of blastocysts that we obtain. If we decide to start the second stimulation, we do not measure anything. We start the stimulation, and 6, 7 days after, we do the first ultrasound without measuring anything.
Yes, okay. Then your constellation, when you have no oocyte retrieval in the second cycle, do you see the progesterone?
Never.
Neither. Okay, thank you.
Are there any
But
questions?
I explained why never. I mean, not because I hate progesterone. Never, because we never do the fresh embryo transfer. So it's not, there's no sense to measure progesterone, because you can measure progesterone if you do the fresh embryo transfer. Otherwise.
Further questions in the audience?
Yeah, I have one question. I don't know if Sesh can hear me. It's a question to Sesh Sonkara. Sesh, you mentioned a lot about oocyte number. I want to hear your opinion on the metaphase 2 oocyte. I mean, because we talk a lot about the total number of oocytes, but if we consider, I mean, patients with poor ovarian reserve, and obviously we need the metaphase 2 oocytes to move the cycle forward. And have you looked into your data, see if the correlation is appropriate for us to translate what we get in terms of the total oocyte number to metaphase 2 oocytes?
Can we fix the...
You're muted.
Yeah, sorry. I'm unmuted myself. Thank you for the question, Sandro. So we've not looked specifically at mature oocytes in relation to oocyte number, but if you want to look at, if going from studies that looked at mature oocytes in relation to oocyte number, not across various ovarian response groups, generally, more oocytes, you have more mature oocytes, because the subsequent preclinical and clinical outcomes also, if you're starting with oocyte number and not necessarily metaphase oocytes, I mean, all the clinical outcomes and the preclinical outcomes are positively correlating with the number of oocytes. So it only makes sense that the mature oocyte number also will positively correlate with oocyte number. But again, it might be different with different ovarian response groups, but on the whole, they would correlate positively, and that is what is shown by studies, which is not the primary outcome, but in their secondary outcomes.
Thank you, Sesh.
It's lunchtime.
So, in other words, if I may repeat, what I was trying to reinforce, the suggestion to give a minimal stimulation whereby you voluntarily reduce the number of oocytes to an arbitrary number of 8 or 9 or whatever is more of a conviction or a belief rather than showing by data, because we've seen data from different parts of the world, different centers, multi-center, observational studies, real-world data, randomized, which are showing the same thing again and again.
So we have two questions online. One is, do you recommend using 3D automated antral follicle count measurement, or is there still room for measuring antral follicle count by adjustment in 2D ultrasound scans?
It's for me?
I believe so.
I beg your pardon, sorry.
The question was,
Yeah.
do you recommend using 3D automated antral follicle count measurements, or is there still room for measuring antral follicle count by adjustments in the 2D ultrasound scan?
The 3D. Well, we have used the 3D for many years, mainly for research purposes. We have worked together side by side with General Electrics in developing the new software. The first version was the Sono AVC, then there was the Sono follicle, antral follicle count, and every time there was some improvement. But what we found is that, of course, this may contribute in reducing the intra and inter-operator variability, but in the end, it's not fully automated. It's not a fully automated system. I mean, it needs that you work offline and you have to manage the video and the pictures. Just to say that sometimes, yes, it takes time. And you may agree with me that we, as gynecologists, as IVF doctors, we take into account our time. Sometimes we do not want to spend our time in finding that probably the antral follicle count is not 6, but it is 8, because in our mind, this is not moving, it's not changing the story. And probably this has also been understood by the companies, because in the end, General Electric is the only company, to my knowledge, who developed such a tool. I mean, there are so many other companies producing ultrasound equipment, and I wonder whether they have not given us something similar.
Well, it's a little past 1 o'clock. We're running a little bit late. They've asked that I think we'll adjourn for lunch, and they've asked us to return at 2:15. And again, I want to thank the audience and the
Ciao Filippo, ti
organizers.
saluto perché parto, devo andare a Lugano.